Okay. Okay, great. So now it's recording. There we go. All right, so this is an article by Sutton and others, and this was in Pediatric Critical Care looking at key points to CPR. And the main issues are that survival outcomes in pediatric cardiac arrest have been improving. This primary area of improvement that we've seen, though, is actually in hospital cardiac arrest. We haven't seen much of an improvement in out-of-hospital cardiac arrest as yet. Most of this looked at data that back in the late 90s, the percentage of survival to discharge for in-hospital cardiac arrests, those occurring in pediatric ICUs, was only 14%. And recent studies published in 2016 are showing that we're approaching survival rates of 45% now. And the majority of this is related to improvements in return of spontaneous circulation. That sounds like that should be obvious, but the rates of return of spontaneous circulation prior to that were less than 50%. And so with the less than 50% rate, you only had the 14% survival to discharge rate. Now with rates approaching 78% of being able to regain circulation, we're seeing a 45% survival to discharge. So there's still, this is still a rather lethal component for many patients, that even in being able to get a pulse back in them, it's not ubiquitous that those patients who get a pulse back are going to survive to discharge. And much of that has to do with the underlying etiology is why they went into a cardiac arrest to begin with. But this change in a short period of time, and really 20 years is a relatively short period of time to see such a dramatic increase in outcomes. And so the authors were looking into this, they realized that, really what's been changing is the improvement and attention to the quality of CPR that's being provided. So much of the issues that changed in 2000 and then 2010 and 2015 guidelines, and this whole goal of getting with the guidelines to improve chest compression quality was really the biggest factor here. And having that finally get out to the community and get to the levels where the PICU teams were also performing better CPR really changed things. The table at the bottom, if we go back one slide, the table at the bottom is what showed the changes in outcomes. The next table, on table 2, is looking at what the quality targets are during CPR. And so this is divided based on age. So the depth for infant and children is at least 1/3 of the anterior posterior diameter of the chest, which is around 4 centimeters in infants, around 5 centimeters in children. The depth for adolescents is really pretty much similar to that in adults. It's at least 5 centimeters. They're suggesting 5, but no more than 6 centimeters. It's really hard to gauge when you're doing a chest compression with your whole body against somebody's chest that you're going to be able to tell the difference between a 1 centimeter difference. But in both instances, the evidence that's given to the teams to resuscitate is the idea to push hard. And so that hard push typically gets you there. And then the next issue is to push fast. So in children, the rates are 100 to 120 per minute. The CPR fraction time is another important part that we're going to come up to. And that CPR fraction refers to the amount of time that you're actually performing chest compressions. And then any interruption to that is where you start to create a fraction. So if over 5 minutes you're doing chest compressions and you pause for a minute, then that's basically an 80% fraction of chest compression. So the idea is to have that be the largest fraction that's seen, otherwise to minimize that fraction and to try to approach 100% as much as possible. That is probably one of the most important components with pediatric arrests right now. And the reason I'm saying that is that the issue of resuscitation in any person, child or otherwise, is often a focus on airway. And for pediatrics, it's an important focus on airway too, because airway is often a primary etiology to the cardiac arrest. But what this data suggests is that while we need to have a aggressive approach to airway management, we need to recognize that we shouldn't be stopping chest compressions for airway management. And if we're in a scenario where we're having to stop chest compressions in order to manage the airway, we should consider other alternate airway management strategies. And that's probably the most important part of this article, is sort of getting at that balance of how do you improve the highest likelihood of survival to discharge, and having good outcomes with that survival. And part of that really is being aggressive with the airway, but at the same time recognizing that pauses and compressions are just as deleterious as not getting the airway itself. And so trying to maintain a CPR fraction and having that idea of what a CPR fraction is and knowing that that's a goal is important for the whole team to understand. And so if we're out there and we don't understand these terms, then it's really influencing team behavior. Because if there's not a situational awareness of what you're aiming for, what the target is, it's like playing a game of darts where nobody knows where the board is. And so you can imagine if you're in a bar with somebody who's like that, playing blind darts, someone's going to get hurt. So this is an important component, and why I want to really kind of flesh that out and bring that term to the forefront. And then in addition, there's the importance on ventilation rate. It's just as important to avoid excessive ventilation in a child as it is an adult. The issue of overventilation leads to increased intrathoracic pressures, and the higher intrathoracic pressures are not offset by the chest compressions themselves. And so it impedes venous return when you have high intrathoracic pressure. Therefore, your stroke volumes every time you're coming off the chest are smaller. And so it's important to understand that interaction. You can think of it as, if you normally needed to survive on tablespoons of blood flow with each stroke volume, and you're overventilating, you're only going to be providing teaspoons of blood flow. And so that's going to impede neurologic recovery, and it's going to impede, most importantly, coronary artery perfusion pressures, which are what is necessary. That's the metric necessary to get return of circulation. If your arteries aren't being perfused in the coronary arteries, then the heart's not going to resume its spontaneous movements. So again, there needs to be a excessive attention to ventilation so that we're not going beyond 10 ventilations per minute. And then lastly is the issue of allowing full chest recoil between all compressions. One of my mentors and research colleagues was Jim Neiman, and Jim Neiman was a researcher at Harvard UCLA, and he worked with some pretty incredible cardiologists as well in terms of their research back in the 70s and 80s, and published reports on the mechanics of CPR. And what used to be the thought process about CPR was that it was this mechanical compression of the chest, and that as you were compressing the sternum against the right ventricle and left ventricle, and then as you did that, the blood was expelled from the ventricles with that deep chest compression. And that so a good strong push was an important component of that. And what was interesting, what was kind of a set of studies that challenged that idea was Dr. Neiman's research, and with Dr. Criley. And Dr. Criley was a really experienced cardiologist, and he had noted in the cath lab that when patients went into ventricular fibrillation, if they were coughing, they maintained forward blood flow. So just the act of coughing allowed that forward blood flow to be maintained, so much so that if you coughed in a staccato cough during VFib, you could maintain your own circulation just by the persistent cough. And so Dr. Neiman looked at that and said, well, why don't we take this to the lab and see if we could induce a cough? Let's go ahead and we'll anesthetize some animals, and we'll put him into VFib arrest, and then we'll stimulate the diaphragm to cough and see if that improves it. And lo and behold, they noted that that perfusion was maintained through that reflex. And why that was such an important finding was that it demonstrated that the forward flow wasn't related to the chest compression, the actual compression of the ventricle, because when you actually looked at this, and then you looked at their studies of how much blood flow came out with the compressions, there was an equal amount of force of the directions that the blood would go. It would go out the atria just as much as it would go forward, just based on the compression itself. Where the forward flow really occurred was in chest recoil and relaxation. So the relaxation portion of this is the most important part of the chest compression. That's when you're actually getting diastolic flow. You're getting a change in the thoracic pressures. So it's a change in thoracic pressure, which is a bigger component, rather than just the forward systolic sort of movement of pressing down. And that research led to a number of different devices being made that focused on improving intrathoracic pressure differences. And that's really why it's so important, and why it's emphasized now that we have this idea of full chest recoil. It was based on this cough CPR technique that Criley noted and that Neiman then proved in the lab together. It was a really cool finding. So where are we going with this now? Now, we're starting to go towards what's called vector-driven CPR. And the vector-driven CPR is a newer term of an old thought, right? So what was our vector before? Our vector before was getting return of circulation. But the issue is that that's what we're aiming to achieve. And so having that as a vector was always difficult, because basically you were doing compressions, and then trying to see, well, did we get return of circulation or not? And the answer was no. Okay, back to compressions. And there isn't much of a feedback loop in that, except for the obviousness of having a pulse again. So during CPR, there are ways of improving the quality of CPR and recognizing its quality. And so the objective measures are now to use other physiologic monitoring, and that includes end-tidal CO2. So end-tidal CO2 levels are shown here during a patient who's getting chest compressions. And this was a particularly good CPR that was being provided, so there was minimal interruptions in the chest compressions. And what you see when they initiate the chest compressions, that there's a low end-tidal CO2. And that as the chest compressions continue, the end-tidal CO2 begins to increase and increase and increase. And this is because the perfusion is increasing. And as the perfusion is increasing with gas exchanges, you're seeing improvements in end-tidal CO2. And then when spontaneous circulation is restored, you can see much higher levels of end-tidal CO2 that are obtained. So in general, being able to now witness what the physiology is during the CPR is helping us to realize if we need to make improvements in our chest compression quality. This is an area of research that I've spent a lot of time in as well. Yeah.
I'm not sure you're aware. I don't know if you guys have heard the news either, but we are purchasing new Zoll monitors. Mm-hmm. They'll be coming at the new year, and we'll be doing training on them, but they're going to have one-step pads that are going to provide real-time feedback during the CPR. Like they'll say push harder or push faster, and it's also going to have the end-tidal monitoring on our Zoll monitor, so you can see what the end-tidal is.
Yeah,
so that's coming up.
Do you know in their age or weight, or how does it know?
Because it's different. It's Zoll, but there's another device.
There's an accelerometer on it that tells you the difference.
And so when you do the compressions on it, it's going to tell you. It's going to say what your depth is, what your rate is. If it's too slow, if it's too fast, it'll announce it back to you.
How does it know if you're working on an infant or a 3-year-old?
The pediatric pads are different than adults. So once you plug in the pediatric pads, it'll read it as pediatric. So it'll know that you're on. That'll be coming up in the new year, so it'll be good to have.
Yeah, that's so. I'm aware that is exactly where I'm giving this talk. So, and why specifically I'm using end-tidal CO2 to talk about this. The end-tidal CO2 has some drawbacks. And so I just wanted to kind of bring that up. So I was going to mention I've done research on this, both mainly in adults with end-tidal CO2, and then in pigs with near-infrared spectroscopy. And the near-infrared is basically like a pulse oximeter, except it has a greater beam length, and it doesn't require pulses to be present to measure oxygenation. So that's what's the interesting part of what's called NIRS. And we used this in the lab and could see that not only could we see improvements in chest compression by using it, but we actually could tell who was doing chest compressions because there's a signal that you develop on a NIRS, or you can actually tell, like, based on the rhythm and based on their movements and stuff like that, you can tell when you go from one compressor to another compressor because of this sort of identity that you develop with the device. End-tidal CO2 can demonstrate that as well if you have somebody who gets on the patient who's doing CPR that's not of the same quality. So this is an important component because we're changing chest compressors generally, hopefully every 2 minutes to every 2 to 4 minutes, we should be changing compressors. And as we're doing that, we need to know, are we achieving the same quality of compression from one change to the other? And you can tell, like, when we're doing this with students, that answer is definitely no, right? Like the student needs to be coached really quickly during the case to kind of come up to speed, and some get it and some don't. And so there's an important aspect of this, and the getting it and not getting it has nothing to do with body size or anything else like that. I've seen people of small stature do great chest compressions, and I've seen people with large stature do really poor chest compressions. And so it's really an issue of just having the physical skill and kind of timing to be able to do that correctly, do a good hard push, and allowing the good recoil to occur at the same time. Just that it's a coordinated movement like anything else. And so so the issue with the NIRS was that we could see subtle changes that you can't see in end-tidal CO2. Also, we could see significant differences when end-tidal CO2 wasn't accurate. So the interesting part about this is end-tidal CO2 can lose its accuracy when a patient has just arrested. And the reason that is that those patients who just arrested are very responsive to vasoconstrictive agents. So when you're giving epinephrine, you're causing pulmonary vasoconstriction as well. And so your end-tidal CO2 levels may vary based on that. So based on your responsiveness to epinephrine, your end-tidal CO2 may or may not be as accurate from that. And so you may actually see some patients, and this is what I saw in a study I did with Dr. Eckstein in LA County, was that we were trying to come up with a prediction rule for the paramedics that if they measured an end-tidal CO2 of a certain value, could they say, I should just stop CPR. I shouldn't continue because I can't achieve an end-tidal CO2 of X amount. And we could come up with a cutoff number, no matter how low, because there are patients who started off with low end-tidal CO2 who, as you can see here, continued to increase and increase and increase. And so then we said, okay, well, what if we look at the change in end-tidal CO2? If we looked at this and said, okay, if there's zero change in end-tidal CO2, can we stop with that patient group? And we couldn't, because we had a group of patients who had end-tidal CO2 that began to decrease during CPR that had return of spontaneous circulation. And so I went to Dr. Neiman. I was like, hey, help me figure this part out because I don't know what's going on here. And he was like, oh, that's simple. He's like, that's a group that was responsive to epinephrine and was having pulmonary vasoconstriction. He's like, so the fact that they actually went down was a sign that you were capturing them at an early phase of their cardiac arrest, not at a late phase.
Why would they continue to increase if we continue to give epinephrine every 3 to 5? We want to increase SVR, so we're causing a vasoconstriction through the whole arrest sequence. Why would it Why would it increase if we continue to vasoconstrict?
It's increasing because end-tidal CO2 generally is more of a correlate for perfusion. So you're increasing perfusion. So your end-tidal CO2 levels are...
So despite the vasoconstriction, you're getting better perfusion.
Right. So, except there is a certain group of patients that you get to whose end-tidal CO2s are, let's say, 15 initially.
Mm-hmm.
You're giving them compressions and you're giving them epinephrine, and in response to epinephrine, there's a quick response, and end-tidal CO2 levels drop because the pulmonary constriction was more profound in a patient who was earlier in their CPR, earlier in their cardiac arrest, in terms of the timing, in terms of a lower downtime. So
the longer you're providing artificial circulation, the better their end-tidal will get.
Generally, yes. Except for this small group of patients that had a short downtime. And so the purpose of bringing that out is not to try, I don't want to confuse the situation. The end-tidal CO2 generally correlates with better perfusion, but there are a group that early on that won't. And so I just wanted you to recognize what the limitations of end-tidal CO2 are. With that being said, the authors here really basically just discuss how end-tidal CO2 is used to detect return of spontaneous circulation as well. And then as you see, when you see a rapid increase from the chest compression here from this, sorry, you'll see it up on the screen here, but on the, you'll see a threshold change where they go from increasing the end-tidal CO2, and then finally when spontaneous circulation occurs, there's a rapid incline. And this has been an important part in terms of research in this area, is trying to determine when should you stop chest compressions, and recognizing when there's actually adequate perfusion that's been restored. We've always been doing this by just the presence of a pulse, but sometimes we continue CPR for several minutes before we do a pulse assessment. So this allows us to recognize that earlier. In general, we've noted that the end-tidal CO2s correlate with the compression depth and ventilation rates. So this is where we should be able to see if somebody is being overventilated, we may see their end-tidal CO2 drop during CPR. We note that we need to try to maintain ventilation rates around 10 per minute. And then if we're not seeing adequate chest compressions, the end-tidal CO2 may drop as well. We know that we need to improve either the rate or depth of compression. This is really just the tip of the iceberg, and I think in terms of what we're going to see with vector-driven CPR. And as we get better units for these near-infrared devices, we should start to see improvement with that as well. So I know that Zoll is starting off with this. This is what they have ready now, but I'm also aware of what Zoll has, at least what some of their engineers have begun protecting in intellectual property. And so that intellectual property things that they're beginning to protect are looking at multimodal devices to drive our CPR.
On that time axis, you can't really tell, but is this a compression? So if I'm reading it right, after about 18 compressions, you've achieved your target end-tidal CO2 on that bottom axis.
Right. So these are generally within about 30 seconds or so, which is going to be technically within about 50 chest compressions or so, you should be demonstrating where that compressor is. So this is going to be the part that when we bring the Zoll in, there's going to be the issue of being able to see this and recognize how, the information that we're getting. But more importantly is we're going to need to focus on determining when to begin coaching somebody to change. So the likelihood is that you have somebody do chest compressions for under 30 seconds, and if you're not getting an end-tidal CO2 where you think it could get to, then change chest compressors or change techniques for that compressor until we see what their maximum is.
You coach them to allow a greater filling time? And so you're not getting your target CO2?
Yeah, and I've been doing, I mean, right now we do that already, right? Like I generally focus on the chest compressors during CPR anyway, and often will model for them what I want. So I'll go over and do that. And the confidence in modeling for them what I want comes from the years spent in a lab of having more robust physiologic data. So, when I'm in the lab with the pigs, we have like a bunch of monitors are up, and we can see the aortic pressures, the right atrial pressures. Because you can see both of those, we also have a monitor that's showing us the coronary perfusion pressure. So when we're in the lab, we're actually using coronary perfusion pressure as our vector feedback. And it was one of those things that you're sitting in the lab, you're doing this, you're wondering, like, when are we going to get to someday where we could do this with our patients? Because if that's what we're using in our lab to determine who should be on the chest and who shouldn't, wouldn't that be that'd be the best tool of all?
In a non-invasive way, that could it be applied quickly?
Right. And so right now the idea is that, we're using the entitled, we're going to use the entitled to do that. But the important part is being able to recognize what is the data that you need and how are you going to adapt and make those changes. And so because I was in the lab doing this, I could see what a good chest compression was, and I know what the feel is to it. So often, I think that if you have somebody that's new at doing chest compressions, that maybe isn't the time to have them be the first person on the chest. It's probably better to have somebody model chest compressions for them so that they can then see, oh, this is what I need to do. And well, you could say, well, everybody's seen the videos, they're all ACLS certified and thus, or BLS certified at least, and at some point did chest compressions with somebody watching them. But the fact of the matter is, in the midst of doing all this, we know that bless you, we know that learning is limited, and we see that especially in kids as well. The quality of chest compressions in kids and the resuscitations in kids, particularly for airway management, we noted that teaching people how to do intubations in kids when we did this with the paramedics, there was a fast decline in their skill set because there was a lack of practice. And so this is a welcome measure for us to start using some form of a vector-driven device for children now too. Otherwise, let's see here. That was kind of pretty much it. When we looked at oxygenation, ventilation, there really isn't much of a change. I think the only important part here is that often there are certain caveats in children in CPR. In neonates, the general rule is that you use room air for oxygenation. The studies of neonatal cardiac arrests were that the neonatal brain is more sensitive to hyperoxygenation, and there's additional injury that occurs in hyperoxygenation, and that neonates that were resuscitated in room air had better outcomes than those that didn't, with the exception of kids that don't have, that are very premature and potentially have no ability, very little ability to oxygenate because they lack any lung surfactant. And that's something we'll come back to later when we talk about ARDS. But the long and short of it is, in neonates, it's usually a normoxic room air resuscitation. We're aiming for that in all resuscitations to have normoxia. But normoxia is defined as a PaO2 greater than 60 and less than 300. And I think the important part of that is that when we get our first blood gases back and we've got somebody on a vent like this, that, if the blood gas comes back at 240 and that patient's arrest is related to pneumonia or some other primary lung injury, that there shouldn't be this quick decision of, I'm going to try to push the FiO2 down right away. That having the PaO2 less than 300 is the goal. That this idea of, the idea that you're going to try to be between 60 and 100, there's no research that shows that makes any improvement. There's an issue that if you have hyperoxemia where it's greater than 300, that's when you begin having injury that's noted. So I just wanted to kind of draw that kind of detail out, because there is sometimes an over enthusiastic emphasis to drop the FiO2, sometimes prematurely, and we know that hypoxia leads to far worse outcomes. So we need to avoid hypoxia and at the same time manage hyperoxia if that's occurring. And then otherwise, here's another study also where they looked at an observational study in hospital cardiac arrest, and they noted that hypocapnia, meaning that the PaCO2 is less than 330, and or hypercapnia, when it's greater than 50, were both associated with mortality. So that goes to both issues with the ventilation issues, that if you overventilate somebody, their PaCO2 drops and gets below 30. And that causes a worse outcome. And if you underventilate them, their PaCO2 goes over 50, that's a worse outcome. So there are all of these Goldilocks effects in pediatric resuscitation, where too little is too much and too much is too much, and it has to be just right. And so the goal here is to be between 30 and 50 to have the greatest likelihood of good outcome. And then the only other aspect to make mention in kids in particular is that, and this happens in adults, but kids are a little bit more susceptible to this, is post-cardiac arrest seizures. It can be present in up to 30% of patients. And so it's important to consider how you're going to manage that. In general now, the focus on that management is using a drug like Keppra, as opposed to using benzodiazepines, because the benzodiazepines can further cause hypotension. And so the additional hypotension following cardiac arrest is an undesired outcome. And so Keppra is less likely to cause hypotension, and so therefore is the better drug to consider. It's also important to consider that these patients should have early EEGs done to determine if they're having subclinical seizures or not. And that's why we're saying it can be present in up to 30% of patients, because often this isn't being monitored, and the subclinical seizure is by definition subtle and difficult to recognize at the bedside, and so you're only going to recognize that through measurements. Similar to hypoxia, right? Like how your estimate of hypoxia at the bedside is really low. You have a device to measure pulse ox to inform you. We should be considering measurements for evaluations for seizures in post-arrest patients more often. And I don't mean to sound like a broken record, but it's in the paper, so I'm just reporting what's in the paper. So ECMO, all right? And so there's discussion of how ECMO has improved survival in pediatric arrests. And looking at this, there was a large study that was done where a large majority of patients that were placed on ECMO, and these are kids that are in really bad shape, obviously who are generally refractory to traditional CPR, who are getting 77% of them are getting return of circulation.
Who's doing this practice?
So a whole bunch of places, and the reason, Sharp does locally for the emergency department, but
adults only.
But the research, in ECMO resuscitations, when you look at the history of it, really pretty much began in children. The initial person where we had a successful ECMO resuscitation was in a 24-year-old who was in a traumatic accident. But the next set of studies that followed that adult were all pediatric patients, because the physicians that were involved in that research were out of UC Irvine, were doing research between Irvine and Children's Hospital of Orange County. And so for decades, ECMO was in use and was common in pediatric hospitals all around the country. And it's been a common tool in pediatric ICUs. It for some reason has had a slow adoption rate for adults and had a slow adoption rate for eCPR because of the lack of knowledge about it and the lack of procedural competency to perform it. And so, you know, if you're a French cook and you don't know how to make Japanese cuisine, you're not going to do that. It's not going to happen, right? So if you're an ER doc and you don't, or an intensivist and in adults, and you haven't done ECMO in kids, you don't think of that as a tool to apply to adults. And so it took some time for adoption of that, and that's kind of what the paradigm shift was at Sharp, where the ER doctors began to adopt that as their practice, and now that's spread to Scripps and La Jolla, where they're doing this as well. And it's really interesting to see how this is sort of evolving in that aspect. But across the states, there's a ton of programs that do this in kids, and you can imagine that in ERs, there's often been an issue where there's been reluctance to place these devices in kids, again, because there's this idea of, well, this isn't going to work. It's like, well, it's not going to work because you don't have the experience of doing it, not because no one else showed that it works. So here's data and large studies that showed that, you know, in this one study, more than 15% of the 77% patients who achieved return to circulation did so through the use of ECLS. And these kids generally have good neurologic outcomes. So the skepticism that you're putting them on ECMO to then be maintained in a vegetative state isn't well supported by the literature either. Most of these kids, like if they're going to have a poor outcome, most of them die even on ECMO. ECMO just provides oxygenation and circulatory support, but it's a support. It's not a complete replacement of. And so there are situations where, as you begin, if you're in septic shock, ECMO doesn't change multi-organ failure. There's other management strategies for that, but if multi-organ failure is going to be a definite consequence of that patient's fate, then that's what's going to be the case. So similar to some patients who have severe vascular disease, that will be their fate no matter what you do. Anyway, so in here, the authors note that in the recent Get With the Guidelines revised study, they looked at patients from all illness categories who received at least 10 minutes of CPR, and they found that ECMO CPR had improved survival and favorable neurologic outcome at discharge compared with conventional CPR, and even when they matched them for all sorts of other categories of risk. So most experts are agreeing that there's suitability for eCPR rescue and that this needs to be individualized at the patient level, but considering reversibility of underlying causes is an important part of that. But this as a technique is a very relevant technique. Now, the biggest recent challenge to eCPR now is a decision that Centers for Medicaid just made on October 1st of this year, where they just decreased the reimbursements for ECMO placed percutaneously. So the average reimbursement all the way up until this point has been over $100,000 every time you deploy an ECMO device. And now they want to change the reimbursement to $8,000.
What?
That's
Yeah.
a great disincentive.
It's a disincentive, and the issue is that it's gonna potentially kill a lot of programs if that reimbursement schedule is allowed to continue or not. There's a fight going on about this. The issue was that when you open up a peripheral packet to place the cannulas, those cannula packets are about anywhere from $12,000 to $18,000. So if you're only going to get paid $8,000,
You're underwater when you open
you're underwater the second you open the packet, and the more expensive packets are usually used in devices that don't require perfusionists, which are meant to save considerable dollars. So even if you had a cheaper packet, and the cheapest packet for this is $2,000, it comes with a really huge device and all these other things that are part of this. And the device setup itself is about $150,000 then for that device. So you either have a device that's $40,000 with packets that are 16 grand a piece, or you have a device that's $150,000 with packets that are 2 grand a piece. But the 2 grand packets have these really long tubes, and they cause significant dilutional effects when you're connecting them. And as a result of those dilutional effects, you need to have a perfusionist involved in their care. So your operating costs skyrocket in that setting. So in either scenario, it's an expensive process to perform. And so we'll see how health policy and reimbursement issues are going to affect whether or not programs are going to close down their ECMO services or continue them. But it's a new wrinkle. All right. Next, the next issue that we're going to discuss is management of issues in critically ill pediatric patients with trauma. And this is an article by Dr. Ahmed and Bird, and it reviews a number of typical things in pediatric trauma. I mean, the common theme in pediatric resuscitation is that they're not small adults. And as much as that's repeated over and over again, the most interesting aspect to me is that every time you read up on studies of pediatric resuscitation, most of the research that's used to support it is based on adults. So we could say that they're not adults, but there is a majority of the research on the physiology of resuscitation is based on adults and extrapolated to children. And so in this article, they recognize when that occurs, and so they provide us some examples of when there are some differences and when we do have some pediatric-based data to base those decisions on. So the first part is just looking at fluid resuscitation. The general fluid resuscitations are no different than you've already been taught in ATLS. It's a 20 cc per kilo bolus to repeat the bolus if needed, and then if there's still requirement for support to begin a bolus of packed red blood cells at 10 cc's per kilo. And that has been the sort of standard treatment. Now, are you guys aware of any other treatment strategies other than that?
Well, that's what we're taught now. You give a bolus, repeat it one time, and then you replace blood with blood. So you start blood products after the second bolus if they're a transient responder or a non-responder.
Right. And then what?
You continue to replace blood products until you plug the hole.
Okay, so until there's control of hemorrhage, blood products continue. To what amount?
Until you achieve surgical control.
Okay, so until there's an actual
Right.
hemostasis that occurs either surgically or otherwise. Now, the surgical aspect, I'm going to come back to. There's, back at SC, there was when we had a different, we have a different strategy to trauma resuscitation at SC than most other places did, right? Because the ER doctors run the trauma resuscitations, and there was a challenge to that throughout the history of our strategies. And one of the challenges was, the trauma surgeons should be doing this because they're the ones taking them to the OR. And we looked back at the data, and the data demonstrated that less than 10% of patients that came in as trauma patients went to the OR, and that the majority of these patients required an aggressive medical resuscitation. And Dr. Dimitriades was a key component to developing a strategy that had the ER emphasized as the resuscitation strategist in that because his research had demonstrated, out of his studies out of South Africa, had demonstrated that many solid organ injuries didn't require surgical treatment. And so, probably some of his most influential research was looking at splenic injuries, right? It used to be that kids that were involved in accidents, in car accidents in particular in the 70s, were having their spleens removed left and right. That was the strategy for hemorrhage control, was a splenectomy in those situations. And his data challenged that and looked and said, no, you could have a grade 3 injury and not require surgery. And then there was like, well, then all the grade 4s must go. And he was like, no. Not all the grade 4 injuries need to go to surgery either. Some of those can be managed better with embolization. And so what we've noted over the years is this trend away from surgical management of hemorrhage and looking at ways of non-surgical methods. Now, the flip side of that is the patient that's exsanguinating, right? And the biggest challenge to the exsanguinating patient who's bleeding so much was Dr. Holcomb's research, where and others, it's not just Holcomb, but Holcomb had some of the best data on this, of damage control surgery. And the purpose of damage control surgery is to just arrest the areas of major hemorrhage and then go back for fine repairs later. So the whole focus of damage repair surgery is literally just find the areas that are bleeding, stop those areas from bleeding, and then leave the abdomen, like for laparotomy, leave the abdomen open, pack it, and then we'll come back to surgery in 48 hours.
Well, that makes sense, because the less length of time that you're exsanguinating, you're not dealing with DIC and coagulopathy. And since we don't have ROTEM or TEG here, our process for delivering FFP platelets and cryo is what the surgeon sees as he's, oh, is this hemostatic or is it not? What do we need to give based on physical findings instead of our lab data? Because we don't have that here.
Right. Even the TEG data is not really all that great with directing this. There's been a lot of research recently looking specifically at TEG TEG-directed protocols, and they're not seeing changes in outcomes based on that as much. So that's just been lately, within like the last 6 months or so, that there have been some studies. It's I don't know if it's going to fall away, but I think that the ideas are right. The idea is that we're trying to find a more data-driven philosophy for our resuscitation strategies. So it's the right idea. It's just that as a single metric, or even as just a couple metrics, it may not be sufficient for us to do it that way. And it may be because we're humans, and as humans that are looking at specific metrics, we tend to focus and overemphasize changes too much and make decisions based on that. And I've got a part of this talk that will come to that in that decision in particular. But in general here, that's been the general strategy, right? 20 cc's per kilo of saline, repeat the bolus, then start blood at 10 cc's per kilo. Honda brought up the issue of what's really referred to as the lethal triad, which is the issue of a cycle of acidosis with coagulopathy and hypothermia that occurs during hemorrhagic shock. And this is really one of the most major challenges to resuscitating anybody, is that once you're in that, it's a very difficult cycle to break. And so this is where Holcomb's research came in with the damage control laparotomy. And again, the major goals of this were to control active hemorrhage from major vascular injuries as quickly as possible and to limit abdominal contamination. So for instance, rather than proceeding with time-consuming definitive surgical treatments with like an injured bowel, for instance, instead of performing an anastomosis of the bowel, they just staple it. Just staple it, move on. Find the next area that's potentially bleeding or potential area of contamination, and just quickly and abruptly address that. And then the abdomen is covered with an occlusive dressing, and then the patient's returned with a planned return to the OR in the next 48 hours. And I think, you know, the reason we all kind of looked at this and supported this as much as we did was that Holcomb studies were coming out of war-based and large injuries that were occurring as a result of military weapons. Mm. And so he had this whole database on soldiers that were being resuscitated this way, and showed dramatic improvements in outcomes by managing this.
You can optimize their condition though in the ICU. If you pack them or you do an iliac artery embolization, leave them in an open abdomen, make sure they're not hypothermic or coagulopathic, then you return, there's much better outcome.
Right. And you can address, it also gives you a time to medically resuscitate and address the coagulopathy that's developing. And sometimes the cat's out of the bag and you need to just find a way to herd it back. And so you need time. to be able to address that. And that's really difficult that's a difficult part to achieve in the OR. I have this dichotomous training where I started off in surgery and as an intern, and I was at Harvard UCLA for that. And so there the strategy was, and what I was taught as an intern, was the best place to resuscitate somebody was in the OR. And then I flipped to SC where it was like, well, the best place to resuscitate somebody is in the ER, and then take a few of them in the OR that you need to, but otherwise do everything you can to do this. And so having that kind of background created this approach of my own reading of paper of trying to figure out, well, where's the best place to resuscitate this particular patient at this particular time. And I think that that we recognize that the OR is a really difficult place to resuscitate coagulopathy and hypothermia. It's hard to do that there. So you need to be in an ICU. You need to have the adjuvants of a bunch of other therapeutic options that aren't amenable to being used in the OR to address this. And it's a lot of blood assessment, reassessment, and knob turning, so to speak, as opposed to cutting and sewing. And so the other interesting part that came out of the research with Holcomb, besides this damage control surgery, was the use of component therapy resuscitation. And so the idea that you're not just going to give packed red blood cells, but that you need to consider these massive blood transfusion protocols as restoring whole blood. And so in general, this has led to a strategy of replacing all components in massive transfusion strategies of 1-to-1-to-1 ratios. This is addressed in kids just slightly differently, but the important aspect in kids is being able to predict and have an idea of how much blood loss has there been. And so in general, the massive transfusion protocols are used once you've had either an entire volume of blood lost within 24 hours, or if there's been an acute loss of blood of half the blood within 2 hours. So if there's an abrupt exsanguination occurring and there's half the blood loss within 2 hours, then massive transfusion should be initiated. If it's been more than 24 hours and they've already gone through an entire, it looks like they're going to have a need for entire blood volume, that should be done there as well. And so take this next table at the top here estimates, well, what is the circulating blood volume based on age and weight? So for premature infants, it's 90 to 100 cc's per kilo. You figure most premature infants are under 3 grams. So you're looking at essentially 300 milliliters of blood loss is what is an entire blood volume for a kid. So if it looks like there is an injury and bleeding that's occurring that in a premature infant, that's going to be more than 150 cc's in 2 hours, then a massive transfusion should be initiated for that infant, for the premature infant.
Follow the military model of replacing shed blood with whole blood?
Sort of. That's what the very next part is going to be getting to. And then with term infants up to 3 months, it's 80 to 90 cc's per kilo, and then children over 3 months, it's about 70 cc's per kilo, unless they're really obese, which is 65 cc's per kilo. But so more or less, the estimated blood volume is 70 per kilo for children, and once they've lost half of that, then you should be considering this. Or if you estimate that they're going to lose half of it in that time, that within 2 hours, you should begin transfusion protocols. And so this next figure looks at the issue of ongoing hemorrhage and how to manage that. And the key features here are that at the top, there's an issue of the recognition of ongoing hemorrhage. Initially, the clinical signs and vital signs may be stable, and then early presentation of tachycardia and later presentation of hemodynamic instability. And that has always been the issue in children, is that kids are really able to maintain their pressures well until they're not, and then they really just dump. And so the estimated blood loss when they're just tachycardic may be about 20 cc's per kilo, but once they get to 40 cc's per kilo of blood loss, now you're approaching half their volume, right? So 70 cc's per kilo is their total blood volume. And if you're estimating close to 40 cc's per kilo of blood loss, you're in a massive transfusion protocol. And here, the recommendations are to give what's called a 30-20-20 strategy. You give 30 cc's per kilo packed red blood cells, and then if they've lost an entire blood volume, so if they've gone from 40 cc's per kilo to entire 70 cc's per kilo, you begin adding components. And so the initial component you add is 20 cc's per kilo of FFP.
So it's not 1-to-1-to-1 until they're over 30 kilograms?
So it's not 1-to-1-to-1 until they're actually over 2 blood volumes. So when their total blood loss has been greater than 2 blood volumes based on their age and weight, then you're in the 30-20-20 strategy, and you're giving 30 cc's of packed red blood cells per kilo plus 20 cc's of FFP plus 20 cc's per kilo of platelets plus 4 cc's per kilo of cryo. And then if there's still a blood volume loss beyond 2 blood volumes, and that's still ongoing, then the idea is to add and give consideration to giving recombinant factor 7A to have control. Now that's going to be challenged by the folks at UCSD and some other areas where we're using tranexamic acid as a strategy. So I don't want to limit that consideration to just recombinant factor 7A, but I think that's the only area where, and I saw this in the literature, when I saw this in the report, I was like, huh, okay, I'm surprised they left off tranexamic acid, given that that's what we've.
There's no TXA on this slide.
There's no,
read it.
yeah, there's no TXA on this slide. So that was just a surprise to me. So I didn't want to do this talk without at least mentioning that. This was an older study though too. It was from 2010. So that's being cited here. So that might be part of the reason why that was. Here are additional guidelines and strategies. This is the Children's National Medical Center Pediatric Massive Transfusion Protocol, and this is an easier one to read because you're just going based off their age and weight, and just tells you, okay, give half a unit of red blood cells or give one packed RBC. So all these orders are in units. This is much easier to deal with, and so you guys can have copies of this and welcome to look at it and decide if this correlates with our current strategies. I imagine we have a current massive transfusion protocol. I'm sure we have it for adults. I wonder if we have it for children.
Yeah.
We probably should, because we're going to need to transport these kids. And if we recognize that they have a requirement for massive transfusion, if we don't know how to do it, then we're not going to do it, and we're going to.
In the past, when we've received people who are just walk-ins, like a kid was run over, it just hands the kid over, what the surgeons have done is they call Rady, and they get guidance from their trauma surgeon about the care before they can get Chet to fly. And so we don't have one because we're not a pediatric trauma facility, but every time we get a kid in critical shape like that, they do get on the phone with the surgeon.
Okay, cool. And then this is a summary review of just the grades of solid organ injury, livers and spleens and kidneys, and how we define them. Generally, again, a grade 4 injury involves injury of more than either injury of 25 to 75% of the hepatic lobe for the liver. It's for the spleen, it's evidence of vessel involvement with greater than 25%. Of splenic devascularization, and in kidneys, it's a parenchymal laceration extending all the way through the renal cortex and medulla and collecting system. The grade 5 injuries are injuries to greater than 75% of hepatic lobe, shattered spleen, or complete splenic devascularization, or completely shattered kidney. And then the cutoffs are varied based on size of depth and injury for grade 3s and below. The importance of that is that when we look at the different grades here of injury, you can see that the patients with grade 4 injuries have a much higher requirement for admission to ICU. Over 85% of them require that. Even the grade 3s in children are more likely to be admitted to ICU. The number of hospital days are higher in the grade 3s and above. The requirements for transfusion are higher in the grade 3s and above, over double the requirements, if not up to 5 times the requirements compared for grade 4s versus grade 2s, for instance. And the requirements for laparotomy and surgery are much higher. But again, you notice that these percentages here is 12.6%. And that's because some of the grade 4 injuries are better served by embolization than they are by surgery. And then the activity restrictions are greater for this. So generally, the ability to return to full contact sports correlates with this. So if you've had a significant grade 3 or grade 4 injury, you're looking at 6 weeks or longer before they can return to sporting activity. And then the last part to mention here, and this is why this is just in small print here, is just to remind me to talk about delayed diagnosis of injury. This is a much more common event in children than it is in adults. And it's mitigated by a number of factors, one of them being that children are less likely to be as vocal about what their injuries are and what's hurting. It's easy for them to have distracting injuries, so they can have a fracture in one place and the complaints of pain and discomfort are all attributed to the fracture that we know, and therefore we anchored our decision on that and closed off any sort of analytic loops that we would normally apply. So I think the important part is if you have a kid that's requiring repetitive doses of pain medication, keep thinking, at least be vigilant. Is it possible that there's another injury that we missed? And keep reassessing and looking for that reassessment. Don't just assume that the pain medication requirement is just specific to the injury that's either stitched or splinted. There may be another injury occurring. And these delays can occur over several hours to days in some instances. So I had a case where a patient came in who was involved in a car accident. A young kid who was like 4 years old, involved in a car accident, had an obvious deformity to his tibia, and we gave pain medication for that. We got a splint on him and went back and reassessed him several times. Ortho was called for assessment. And was like, okay, I guess, if this kid's compartments are good and he can move his toes and sensations are right, he can be discharged. And I watched him for a while because his dad and mom were in the same accident. And dad, I did a head CT on and kind of watched closely and looked at, and then went back to reassess. And I did a full reassessment head to toe on this kid again. And no other complaints. It was still the leg pain that he was complaining about. And I asked the family members, is he normal? Is this, how he normally is? Is there any changes about him? I don't, and they were like, no. And he looks at me, he's like, can I go now? I was like, all right, well, I guess, clearly like he was at a frustrated point where he was just like, I want to go home. Like, I just want to go. And that's not typical to see from a 4-year-old, but anyway, that's what happened. And so he came back a couple days later and with headache and vomiting, and head CT was done, and he had a head bleed. And so he was transferred down to Rady's. Rady's does an MRI and finds that he has an atlanto-occipital dissociation. The head bleed was actually the tear of the ligament in front of the brainstem that was causing this. And so this is definitely a delayed diagnosis of that injury. And so when I came across this article and was reading that, I was like, oh, I've got a good example to share of how this can occur. And the authors here noted that there are certain predictors of when this is more likely to occur. And it's more likely to occur when there's been a few other instances. This doesn't apply to this case, but when there's been non-accidental trauma, or you're not going to get a full history because the parent's trying to, or the caretaker is trying to prevent you from understanding the mechanism of their injury. And so your ability to kind of think about that is limited. It's also more likely to occur when a kid's pre-verbal, so they're not able to explain what's actually hurting. And it's more likely, the most common injuries that are missed are fractures in general, because you focus on one fracture and miss the others. That was something one of my professors, Billy Mallon, would say to us. He was like, "What's the hardest fracture to diagnose on an X-ray?" And we were like, and we're sitting there and we're like looking at this X-ray of an arm and a wrist, and like, and the issues are, okay, well, it's probably the PC-form that's the hardest one to make the diagnosis because it's the smallest bone. Everyone's coming up with different ideas. And he kind of just lets us flounder for a little bit. And then he looks at us and we realize it was a rhetorical question, because his answer is the second fracture. He's like, the first fracture is the easiest one to diagnose. The hardest fracture to diagnose is the second fracture, no matter what you're looking at. And so in that plays a role in this issue of delayed diagnosis as well. And then the other issues that contribute to this is altered mental status. If patients are somnolent or whatever, they're also going to be more difficult and more likely, or at least have a higher risk for delayed diagnoses. So it's reasonable to have a lower threshold to admit kids and or transfer them for continued observation if the mechanism of injury was concerning enough. So, and I would say that's the lesson I learned. And again, these are the several factors associated with delayed is altered levels of consciousness, barriers of communication, the presence of multiple injuries, blunt mechanisms of injury, and admission to services other than a trauma surgery service, because they may not be doing thorough head-to-toe reassessments and repeating their secondary surveys. All right, and then in the last part of this, we're just going to discuss transfusion decision-making. Actually, we're going to cover two things: transfusion decision-making, and then we'll cover ARDS, and then we'll be done. But this is going to be really short. Transfusion decision-making in pediatric critical illness is, for lack of a better term and kind of cheesy, is to say it's still in its infancy. Our ability to decide when to transfuse and when not to is still hampered. We've looked at protocols of giving transfusions over the years, and there's not been a single protocol that's come out that's demonstrated that that there is reliability in the decision, and that's been very frustrating. So, for instance, the factors associated with giving a transfusion is, one, we want to transfuse when we think anemia that the patient is experiencing isn't going to be well tolerated, and that we think that it's going to go beyond their ability to sufficiently compensate for that. So if they're going to exceed what we think their compensatory mechanism is with their anemia, then that's one reason to consider giving a transfusion. That needs to be balanced with the idea that we recognize now that donor red blood cells is not the same as native red blood cells. That when you're getting stored blood, there are effects of the storage that translate to how the resuscitation goes and how they respond to that. And so donor blood has impaired physiology in comparison, and causes an injury that we call storage lesion. So there's a storage lesion injury with giving blood. And then patients that are transfused for indications other than anemia attributable to oxygen delivery failure have worse outcomes than those who are not transfused to that. So issues of where somebody's having increasing pulmonary edema and you're trying to increase the oxygen delivery capacity by giving more blood, those patients don't do better. They actually do worse. So this means that we need to be strict about when we give blood and why we're giving it. So this is just an illustration of what storage, the overall physiology of storage lesions, that as the storage time increases. So the longer you've been holding on to red blood cells in your blood bank, it leads to increasing oxidative injuries, which leads to increasing microparticles and bioactive lipids that develop, which then leads to effects on the immune system. When you increase inflammatory effects, you increase hypercoagulability, increases risks of infection, and increases endothelial injury. And part of this occurs because the red blood cells that are stored for a long time have decreased deformability. So one of the major factors of red blood cells is that they can deform and move between spaces. And over time, when they're stored, they lose that ability. And so therefore, they're more like you can think of them as like sharp little rocks that are banging against the endothelium and increasing endothelial damage. And that leads to a cascade of increased inflammatory cytokines that are expressed, which further perturbs the injury. And so you're in this cycle of one thing getting worse after another, the snowball effect occurring. And that leads to problems with microvascular perfusion. It decreases now the ability for oxygen consumption to occur. So now your oxygen transport is affected, and now multi-organ failure is more likely to occur in death. So, and all that comes with just a store that falls within the line of storage lesions. And sorry, let me do this up there so you guys can see. So that's what that side is that I'm covering. And there are a few other issues that occur with this at the same time that are related to the storage lesions. It's not just the issue of the red blood cell losing its deformability, but it's a lack of other supportive substrates, such as there's a drop in nitric oxide, and there's a drop in T3-DPG, which also plays an important role in providing acid-base support for this. Now, this is a really confusing slide, and the reason to show this is that the authors are looking at a different approach to decision-making for transfusions. And this gets back to that mention I made earlier, that if we're using TAG as a single component to make our decisions, that we tend to make a yes/no decision based on one test, or maybe just a couple tests. And this shows a decision analysis of how many different things all correspond to coming down to the decision for red blood cell transfusions. And it's related to if you're using a cell saver or not for surgical bleeding, what sort of testing you're doing, what sort of hemostatic agents have been used, how much coagulopathy is occurring, what the current oxygen consumption is for the patient, what the underlying diagnosis is, what's affecting oxygen delivery to the tissues, what's going on with cardiac output, what's going on with respiratory function, and so on and so forth. So they begin to map this out and realize that this is a really complex system, and that perhaps we would be better served by using complex data sources and big data sources to make these decisions and make these computations for us, rather than asking somebody at the bedside to look at just one of these and deciding I'm going to transfuse based on this one decision.
How does this inform the use of the autotransfuser for shed blood in, say, hemothorax cases?
Right. So in the case of a hemothorax case, because you have a large volume loss occurring, it's a little bit more straightforward. You know that you're essentially I'm going to come back and ask you a question back outside of this, but you're already in a massive transfusion setting, generally in that issue. So there's less of a directive of decision making about to give blood or not to give blood. But I want to make sure I understand your question. So when you said with the autotransfusion. So the ATS bags will attach at the end of a atrium chest drain collection. Right.
And then it's a spring loaded, we'll just pull off 750 and then turn it up and give it. It's returning shed blood to the patient.
Right.
It was with regard to the case yesterday where the lady had significant bleed with midline shift, extreme hypertension, and then we just did an intubation post X-ray to find out a whiteout on her right side. And the hemothorax was relieved with a big tube, but our first output was 750, the next one 700, the next one 550. So we just kept turning it over and giving it back. We weren't giving stored blood bank blood. We were giving shed blood back to the patient.
Right. So that has less of the issues. So that you're not going to have so you avoid storage lesion injuries based on doing that. And so that's the benefit of doing that. The total volume requirements may be mitigated based on what the injury is itself. So if the injury is isolated to the chest itself and you can get control of the hemorrhage, then that may be all that's necessary, and they may not require stored blood to be given to them. However, and you're less likely to have issues of coagulopathy because you're less likely to have the cytokines being expressed because you're having a rapid return of native blood, essentially. So that is not covered by this decision making as much, except for the cell saver component in terms of how it plays with blood volume. So I would say the cell saver will have a greater component to addressing your blood volume needs, but not necessarily the decision to transfuse or not to transfuse. So that's where now I understand. I think I understand your question better right now. So
there are less factors related to this if you're getting shed blood.
Right, and this diagram is just addressing, for the most part, the decision to transfuse or not to transfuse. And this is the complexity of the decision of when to do that or not. And this is often why if somebody comes up to you and asks you, are we going to give blood to this patient? This is what's going on in my head. Like, oh, I don't know yet. I'm still trying to figure that out. And unfortunately, choosing a hemoglobin cutoff of 7 and less or under 7 isn't sufficient. We still have patients that get storage injuries as a result of that may do worse as a result of that. We've known that to move the needle down, it used to be, if you were under 10 or under 9, that you got a blood transfusion, and so the needle keeps moving down to 7, and then who knows where that's going to go. But we realize that this should be probably more of an individualized decision and not something just based on a cutoff in and of itself. And so the authors are looking at combining not just that data that's shown there, which are a bunch of different bedside measures, but also looking at using biomarkers. And so looking at troponin as an estimate of injury to the heart, looking at regional tissue oxygenation of the kidney and liver as a way of looking at that, and looking at various different markers for brain injury, and using lactate as an informative marker, and a number of other measures to better derive a plan and decision of when to transfuse and when not to, based on each individual patient. And so at the end of all of this, there's not an overall summary to share with you, other than that we need to make these on an individual basis, and that transfusion is usually appropriately sequenced when other interventions are being considered for its underlying cause, and trying to determine if we think the patient's trajectory is getting worse and requires us to resuscitate them versus not. Any questions about the transfusion decisions? So this was almost like a precursor to this idea that what we should begin to see in the future is this sort of system dynamic, what's called precision medicine approach to transfusion decisions, which are based on multiple inputs of data that's being measured. And some of that may not be up to you at all. It may just be based on the computer algorithm that's reading this, and an artificial intelligence package that's saying, okay, you should transfuse this patient now. So it's going to be interesting to see that some of the clinical decision makings, where we're going to go from using computers as decision support to remind us of things to look for, to moving towards decision analysis and being made by the computer to tell us what to do.
But it comes to my mind, maybe, because when I see a little kid, I just feel like everything, all the cells are new and probably they're not completely developed. And so when we get a donor, it has to be more older than 18. The cells are complete completely mature, and so it comes to my mind maybe some that when they get old blood,
Right.
I could say old blood,
Yeah.
and then their body is just like very tender. They are developing.
Right.
So does that affect
Yeah, so this data and these things that we're talking about, what they've done is they've affected blood banks, and blood banks in hospitals have changed their turnover of blood, their wasting of blood, and the decision for which blood units to use for trauma and for acute bleeding versus other. And so the idea is there was a study out of the State University of New York. I can't remember which SUNY campus it was. There's a bunch of them in New York, obviously. I think it was the one in Long Island that looked at the effect of older stored blood, and found that blood that had been stored for more than 6 weeks had a higher likelihood of this inflammatory cascade being approached. So then they decided, well, in our trauma patients, we're not going to use any blood that's been stored 6 weeks or longer. We're going to use more fresh donations given, and they had improved outcomes with that. So the your perception is not incorrect. There's a difference between older blood in terms of its storage, in terms of who it's coming from. I'd have to know that a little bit better. There may be something to it, there may not, I don't know. Because people who are older may have more comorbidities. There may be other cytokines present in their bloodstream as a result of chronic inflammation that's not present in somebody who's younger without disease. So there's a biological plausibility, I think, to what you're mentioning. I just don't know the data specifically on that. But I'm sure that the people who run the transfusion practices here and have the blood bank, that's probably part of their training and part of their conferences when they go to, is deciding, what do you do? How can you hold on to the blood and that you still think it's useful for a patient before you need to dump it?
It would be hard to imagine there's any human studies with pediatric donors of blood to recipients that are pediatric. Maybe animal models, like young animals donating.
Well, there might be stuff in
blood.
Africa. I mean,
Where the children donate blood.
there may be, yeah, or at least close to it. I mean, there's a younger, I shouldn't say children, or I could say that there's a younger approach that where parents you tend to be the ages of first birth, they're lower in Africa than they are in other nations or in other continents, and transfusion practices have often been from parent to child.
So adolescent mothers too.
Right. So I'm sure that's something that they could discern something from that data. I'll look to see if there's anything out there. There may be. Anyway, so the last thing we're going to cover is ARDS, which is acute respiratory distress syndrome in children. Bless you. This is, essentially a clinical syndrome of pulmonary edema that's non-cardiogenic. It's characterized by being hypoxic, by seeing fluffy infiltrates on the chest X-ray, by decreased functional residual capacity and decreased lung compliance. So you get these wet, stiff lungs that don't transfer gases very well. And the hallmark of this is a loss of what's really called the alveolar epithelial endothelial barrier. And the dysregulation that occurs at that barrier is related to both inflammation and to coagulation. And that's always the really difficult part of this, is that you're impairing gas exchange in your lungs. And you're like, well, it's because fluid's building up in the lungs. It's like, well, no, it's occurring because inflammation is occurring at the lungs and coagulation is occurring there at these vital units where we're blocking perfusion to these important alveolar and endothelial exchanges. And the mainstay of management has been ventilating the patients. But ventilating the patients requires specific strategies. And the strategies are to lower the risk of injury from that. So we call what's called a lung protective ventilation strategy, where we're using smaller volumes of gas to exchange with. So our tidal volumes are aimed at being lower volumes in general to protect from injury occurring. And so those lower volumes are usually estimated to be somewhere around 6 cc's per kilo of tidal volume of what you're kind of aiming for to do that. But then that needs to be mitigated by the issue of having to give enough oxygen. So then you're increasing your FiO2 to balance that. And then it's also mitigated by the underlying perfusion. So if they're not adequately perfusing their lung and they have low cardiac output, then we have to do something to improve the cardiac output. And this is where we start to get in trouble, because as we give vasopressive agents, they also are vasoconstrictive of the vessels at the lung. And so you're pressing on the gas and the brake at the same time while you're driving that car, and it's not as predictable when you do that.
So you drive your practice by arterial blood gas?
So that's what we're going to discuss here. Is, well, what do we do to drive this? What are our targets, and what should we be using to look at this? And the whole issue is, we know that if we do this lung protective strategy, we at least have a decrease in mortality by doing that. There have been a number of different studies and different strategies over the years, including neuromuscular blockade and even prone positioning, that have been shown to decrease mortality among adults. And then they did these studies in kids. And so this is one of the departures, where a study in adults with prone positioning improved mortality with severe ARDS. When they did this with kids, there was no improvement. And they realized they actually had to stop the study right off the bat because they weren't seeing any additional improvements. Now, there's a bunch of different definitions, and I'm not actually even giving you the most up-to-date definition, but I'm giving you one that's close. So out of Berlin came the study looking at defining ARDS across all age groups as being a severe hypoxia, where you have a ratio between what's being between inspired and fractional inspired, so the partial pressure of oxygen and its fractional inspired oxygen levels of less than 300 and less than 200 for ARDS. And that's what the initial definitions were for this, was that you looked at the P to F ratio, and if it was under 300, we called that acute lung injury, and if it was under 200, we called it ARDS. And that's if you have bilateral opacities on the chest X-ray. That then got changed in 2012 in Berlin. They decided, let's get rid of this acute lung injury versus ARDS, and we're just going to call all of this ARDS, and we'll say mild ARDS versus moderate ARDS versus severe ARDS. And so now under 300 is mild ARDS. If it's under 200, it's moderate ARDS, and if it's under 100, it's severe ARDS. And so that kind of helped get rid of some of the differences in studies that we're seeing, so we can compare apples to apples in outcomes and know that, are we looking at how to manage a severe ARDS patient, because that is different from how you manage the mild ARDS patient. And then secondarily to this, looking at minimal ventilator settings for positive end expiratory pressure. So PEEPs greater than 5 centimeters is required. And then they removed any reference to pulmonary capillary wedge pressures, which were present before. This has been since modified as well to look at the other factors of perfusion, such as oxygenation and hemoglobin, but it creates a different unit that's even more confusing, and I didn't want to do that. This is more traditional, and we understand this better, so I just want to kind of limit it to that right now. ARDS occurs from a number of different reasons. It can either be due to direct injury itself, such as that caused by pneumonia from toxins from bacteria, from aspiration and injuries that occur from the substances that you aspirated. Drowning is really included in aspiration. And that inhalational injuries, where you're exposed to gases or other substances that may impede gas diffusion, and or direct lung injury from pulmonary contusion, from actual bruising of the lungs, versus indirect injuries that occur from systemic chemical pathways, such as sepsis, that lethal triad that follows from major trauma, pancreatitis, severe burns, massive transfusions or transfusion-related lung injuries, shock, cardiopulmonary bypass, head injuries, and drug overdose. this is an illustration of the typical unit between the alveolus and the blood, and you realize like how many factors are at play here. And each one of these elements that's illustrated is an oversimplification. But each one of these elements is a potential. If you perturb one of them, it can perturb this whole process. So having epithelial basement membrane disease can cause a problem. And we see that in patients with cystic fibrosis. In patients who have other connective tissue diseases that affect the fibroblasts that are providing support for these units, you see pulmonary disease develop in those patients. So, and we can go on and on with drugs or inhalational agents that poison the sodium-potassium pump, to events that cause increased endothelial cell injury, to this issue of coagulation that can occur, that can affect this. So you realize that anywhere along these pathways, are multiple opportunities to create insult, and that gas exchange is sufficiently perturbed by that. Now when we look at each of these factors, there are certain factors that are more common to be involved, such as injury to surfactant, an issue of accumulation of alveolar macrophages, in addition to excessive fluid that develops, and that those are more common mechanisms. But we still need to be aware of the other mechanisms that exist so that we can finely tune our resuscitations. And so this next one shows you a schematic of the pathophysiology of ARDS. There's a loss of epithelial and endothelial barrier integrity that leads to loss of function. It leads to increased permeability of the pulmonary edema. The solutes and large molecules, such as albumin, begin to enter the alveolar space, and they draw more fluid in with them. The presence of pro-inflammatory mediators are now crossing into the alveoli, and then there's this activated endothelium, which is leading to a hypercoagulability that's occurring, and then at these small vessels. And now you're decreasing perfusion to the unit that you're trying to exchange gases with. So this gives you a good idea of like what the underlying challenges are in your in this resuscitation, and how difficult it is to kind of turn this around. The most common way that we address this is by intubating the patient and putting them on different levels of fractional inspired oxygen. There's been a challenge to this in using non-invasive ventilation. So high flow nasal cannula has been studied in adults, and some studies had demonstrated a worse mortality in patients treated with these approaches. And then there were other studies that also showed some improvement. And so we need to kind of balance that. The idea may be that somebody who's early on in their hypoxic respiratory failure, that by using high flow nasal cannula, so these are the patients with mild ARDS, those patients with mild ARDS may be more likely to be ventilator free at 28 days if you're using high flow nasal cannula. And we have high flow nasal cannulas here. You just have to ask RT to bring them down from the ICU. They can run at anywhere from 30 to 50 liters per minute, and often is a really good adjuvant for a patient that you think is going to be a difficult airway. Because if you think that they're going to be a difficult airway, you can maintain somebody at 50 liters per minute on a high flow nasal cannula, and they can not take a breath for 20 minutes and still be okay. So if you have a patient who is who's likely to have a difficult intubation, it's a reasonable thing to consider as a rescue to have them on this pre-attempt and take some of the pressure off yourself to get this. Now, I've tried this before as well in somebody who had an upper airway issue and did nothing. So if your upper airway is obstructed, you have no airway, high flow nasal cannula doesn't work. If you have an airway and it's possible to pass gas back and forth, and you're doing an intubation for airway protection and or part of their general resuscitation, and it's not upper airway obstruction, then high flow nasal cannula works fantastic. And it really removes a lot of the stress from the quickness that you have to get that airway. So that COPD patient who's not going to tolerate lying down very well, but requires intubation, that's a good person to put on high flow too, because now you don't really care that you're going to overdrive their respiratory function.
It's a temporizing measure.
Because, right, you're temporizing them, plus you're oxygenating them, and it doesn't matter. Like, they're oxygenated, so who cares if they breathe or they don't breathe, because we've shown that you don't need to take a breath with high flow nasal cannula, because it's running and it's circulating at 50 liters per minute. So it's doing an automatic gas exchange for you, and just as long as you have a heartbeat and perfusion, you maintain your oxygenation. That's how that works. So, so in those patients, we should be considering giving high flow nasal cannulas to them. The PEEP that's increased with that is just slight in comparison, and so it's not that big of a deal. Like, you're not as likely to blow out somebody's lung by putting them in high flow O2, because that's the issue when they're being COPD, right? So they're obstructed and kind of plump lungs that aren't really moving; they're a little stiff. So, but so it's something to give consideration to. And we have data here showing that patients with mild ARDS do better with this. But then when you get to patients who have moderate to more severe ARDS, there's no substitute for intubation. Like, those patients just need to be intubated. And then looking at this was looking at the ARDS data. They then looked at a pediatric ARDS study and therapy involving lung protective ventilation as well. And this is where they recommend giving 3 to 6 cc's per kilo of predicted body weight for tidal volumes. And that this more closely approaches the normal range of 5 to 8 cc's that occurs. In addition, to keep plateau pressures less than 28 centimeters, and then to allow some permissive hypercapnia, so allow pHs 7.15 to 7.3 if necessary, if that limits further lung injury. So they can be slightly acidotic, and not to be over aggressive with your ventilatory strategy. And then the goal-directed therapy is to include supplemental oxygen to maintain saturations, and be permissive here too to 92 to 97% for mild ARDS. So again, this is for those levels that are less than 300, more than 200. But for those with moderate disease or even severe disease, that we can even have a permissive hypoxia of up to 88%. So between 88% to 92%, without trying to increase our tidal volumes or increase our PEEP necessarily.
We're not good at tolerating that.
We're not. But the studies are showing us that we need to be a little better about it. And then again, this is in their article, the issue about using extracorporeal life support. And they're citing the Caesar trial, which is an adult study that looked at this and saw that there was significant improvements in survivability for this. The more important aspect of ECMO as a strategy for ARDS management isn't just that it works better, but it's also the timing. And so they looked at the timing of this. And patients who are on ventilators for adults more than 7 days that are in place in ECMO aren't more likely to have a better outcome than not. The prolonged duration of the injury for that period of time seems to be the overwhelming factor. They looked at this in kids as well and looked at a 14-day strategy. The overall consensus opinion has been that if you're looks like you're going to approach more than 7 days a requirement of ventilatory support for ARDS, that there should be early consideration of ECMO. And so that's the important take-home point with that.
And this can all be blown out of the water by the financial reimbursement.
Yep. Because most of these are placed percutaneously and not centrally. They didn't change the rate if you put it in centrally. So if you do thoracotomy and put the ECMO device in that way, you still get the big pay. But if
How's that? That's driving us the wrong way.
It increases morbidity. I know. So there you have it.
Gee, thank you. Very interesting. I especially enjoyed all that blood talk.
I have a little question, maybe related. Talking about giving high volume of oxygen. What about when you have a patient with stroke that also has COPD, but you're not gonna give too much oxygen because then you're gonna, let's say, create
Right, there's the issue of
acidotic on the brain. Oh,
well, right. So if you give the issue of giving hyperoxygenation is that when you hyperoxygenate, you create these radical oxygen species, and they have a deleterious effect on the endothelium. They cause injury to the endothelium. So the inner lining of the vessel is injured by the high oxygen tension. These reactive species have more of a deleterious effect on an injured area, right? So the issue is you've got this vessel that's open until it's blocked. And so the portion that's blocked may not remain blocked entirely. There may be there's going to be some residual perfusion around that. It's called collateral flow. The collateral flow, if it has a high oxygen tension in it, the cells there have already been injured by a lack of oxygen. The higher oxygen tension can also cause further injury on top of that, so that's called a secondary injury. The first injury was the lack of oxygen from the block, and then the secondary injury occurs from your resuscitation strategy. At the same time, if you deliver too little oxygen, that further adds to secondary injury. So it's why there's such a debate and discussion about the balance of post-resuscitation care. What do you do with the patient after you've taken them to the IR suite, retrieved the clot, removed the clot, gave them TPA, did whatever else to remove the block? That period in resuscitation that follows is different because the tissue is now injured, and how we let it heal is different. This is why we have discussions about hypothermia, why we have discussions about preventing seizure, preventing fever, preventing hypoxia, all these other things that increase metabolic demand within an area. We're trying to limit in that post-resuscitative strategy. And it's why there's a field that's growing, that's been growing for a while, but slowly, is this this area of what's called neuroprotection. And so there are critical care stroke neurologists and or critical care neuroprotective people that are trying to influence post-resuscitative care so that we have a better understanding of how to actually do this. Because there's still a lot of controversy with regards to that. You need to, it's like having somebody who's thirsty. They've been out in the desert and they're dying of thirst, and you give them a glass of water, it's helpful. If you open up a fire hydrant on them, you're giving them water, but it's not helpful. So just the delivery of a substrate is not sufficient. It's the manner in which we deliver it that matters. And so I think that's the difficult part of this, that we're still learning.
In the ER, we don't focus on the post-resuscitative sequela. We just think, here, our endpoint is, did we get Ross?
Yeah. Right. Well, thank you guys.
So thank you so much.
I'm ready for the next.
Okay, so I just go to end meeting here, right? How do I do that again? Pause recording, stop recording.